Hello, I'm Neil MacIntyre. I'm a professor of medicine here at Duke. I've been here for 30-some years, and we're going to talk today about some aspects of managing respiratory failure, specifically the role of oxygen therapy and the use of positive pressure ventilation. So what I want to do is break my presentation up into these two broad categories, oxygen therapy and positive pressure ventilation. Under oxygen therapy, we'll talk about conventional approaches to oxygen supplementation, and we'll talk about the new high flow systems. Positive pressure ventilation, I'll touch briefly on design principles and nomenclature because people get that confused very easily. The challenges that we face in 2016, and a brief comment about adaptations for non-invasive applications of positive pressure ventilation. So let's talk about oxygen therapy. When does hypoxia become injurious? As a rough rule of thumb, we say that when the PO2 is below 55 millimeters of mercury and content is below 150 mils per liter of blood, there is a potential for injury. This, however, is very organ specific. For instance, the brain is exquisitely sensitive to hypoxia, other organs much less so. So even though we use this 55 sort of global term, it's important to remember that some organs are going to be hit earlier and other organs are going to be hit later. The human body is quite interesting because there are a great number of compensatory mechanisms for hypoxia: anaerobic metabolism, hemoglobin affinity, cardiac output, increases in hemoglobin, increased extraction by the mitochondria, redistribution of blood flow, and hypoxia-inducible factors. So, especially with chronic hypoxia, the body can adapt to a certain extent. In the acute care setting, our goals of oxygen therapy generally are to keep the PO2, as I say, above 55 millimeters of mercury. And this translates into a saturation somewhere around 88–89%. It's important to recognize that the saturations at rest may be different than those with exercise or those with sleep. So we need to make sure we're covering all those different aspects. It's also important to remember we want to avoid excess oxygen. Too much oxygen can affect the ventilatory control system, especially in COPD. And it's sort of interesting because there probably is a potential for oxygen injury. And some interesting data, coming out of the Netherlands has suggested that you actually can get worse outcomes if your arterial PO2 is above 120 or 150 millimeters of mercury for a prolonged period of time. We've known for years, of course, that in the lung, you can get serious lung toxicity with FiO2 exposures of 60–80%. But as I say, this notion of tissue injury is a relatively new one, but I think it's important for us to remember. These are the conventional O2 devices you'll see out on the floor. The simplest, of course, is the nasal cannula. This can deliver 1 to 6 or maybe up to 1 to 8 liters per minute. For each liter per minute, you get about 3 or 4% increase in oxygen. A facial mask gets you a little more oxygen, a little higher concentration. The rebreather mask has a bag, and what it does is it collects the first part of your or the patient's exhalation, which of course is dead space and has enriched oxygen in it. And then the patient can then take that back in. It's a way of enhancing the reservoir system of a mask. The non-rebreather simply has higher flows of oxygen into it, and it doesn't use that rebreathing feature. And you can get quite high concentrations of oxygen with the non-rebreather mask. Venturi masks are, we don't use those a lot. They are very specially titrated masks with Venturi systems in the tubing that allow more precise adjustments of the FiO2. Again, we don't use those terribly much. And then a face tent is just what it sounds like. It's a big tent over the head. But as you can see, these devices, if you're lucky, can get up close to 100%, especially with the non-rebreather system going at about 10 to 15 liters a minute. Those of you who discharge your patients on oxygen need to recognize that oxygen in the home may not be quite as easy to give as it is in the hospital. Here in the hospital, we have 50 psi sources of gas that can power all of those devices I just showed you. Tanks similarly have 50 psi sources, and they can power virtually everything I talked about. When you go out in the home, however, you're dealing with usually things that have much lower pressures, operating pressures, like concentrators. These can power nasal cannulas and simple masks at low flows, but will not power those masks, those non-rebreather masks, etc., that I described a moment ago. And similarly for liquid systems, again, they can power nasal cannulas, simple masks. And the little graphic here just gives you an idea of what kind of FiO2 you can get out of these home systems. The newest kid on the block is called high flow systems. And there's a lot of confusion about this term high flow. But these particular devices, they're called high flow, high humidity devices. And they generate not 10 or 15 liters a minute of flow, they generate 40, 50, or even 60 liters a minute of flow. And they're delivered through special nasal cannulas. So you're delivering 60 liters a minute of flow directly into the nasal cannula, or into the nasal cavities. That's why it has to be appropriately humidified and heated, otherwise it will become quite uncomfortable. So these high flow, high humidity systems deliver a tremendous amount of oxygen directly into the nose. Now what's the advantage of that? Well, number one, because it's a high flow system, you can get the oxygen concentrations easily up to 100%. Number two, it's washing out all that dead space in the nose and posterior pharynx. So you actually can make ventilation more efficient with these high flows, these high flow, high humidity systems. And a third effect is it probably builds up a little bit of positive pressure in the neck, a sort of a CPAP effect. So for all these reasons, high flow, high humidity nasal O2 systems are becoming more popular, especially in hypoxemic respiratory failure. And many of you probably saw this article in the New England Journal of Medicine, where these devices were used in severe hypoxemic respiratory failure, comparing it to just traditional oxygen therapy or even a non-invasive BiPAP system. And as it turns out, in these hypoxemic patients, this high flow system actually had a better outcome. And these are just the outcomes from that particular study. And as you can see, the cumulative incidence of intubations, the red lines are the high flow oxygen system. And actually in survival, again, the red is the high flow oxygen system, there were improved outcomes. So this is now becoming an increasingly popular way of delivering oxygen to the severely hypoxemic patient in respiratory failure. So oxygen therapy, again, conventional therapy, all the way from simple nasal cannulas, all the way up to 15 liter or more minute ventilation or oxygen in non-rebreather masks are sort of the conventional approaches. And now with the high flow, high humidity systems, we're getting up to 40, 50, and 60 liters a minute of oxygen delivered into the nasal cavity and posterior pharynx. So these are the tools that are out there to help you meet the oxygen goals that we described earlier. The remainder of my presentation, I want to talk about positive pressure ventilation, because this is obviously the mainstay of therapy for acute respiratory failure. Let me talk a little bit about system design and nomenclature, because this gets very confusing. I find the easiest way to understand positive pressure ventilation is to understand breath delivery. And there are three components to breath delivery. There's the trigger, what turns the breath on. There's the gas delivery algorithm, the flow pattern during the breath. And then the cycle criteria, what turns the breath off. And if you think about and dissect your breaths according to these three criteria, you'll understand 99% of how a ventilator works. So a trigger, there are two types of triggers. Number one is a machine trigger. You set a timer. The machine will just trigger when you tell it to, or the timer tells it to. Or number two is an assist mechanism. The patient effort is sensed by the ventilator, and the ventilator responds with a breath. Once the breath is turned on, there are two flow delivery algorithms. Number one, you can set a flow, 20 liters a minute, 40 liters a minute, 60 liters a minute, whatever you like. And you can set a pattern, square wave, sine wave, triangular wave. And the other approach is to not set a flow, but to set a pressure. So you don't set a flow, you set a pressure. You set 10 centimeters of water, 20 centimeters, or 30 centimeters of water. And this is what the ventilator will deliver during the inspiratory phase. So they don't deliver different amounts of gas, but the way the gas is governed by the ventilator is different. One is a set flow, one is a set pressure. What turns the breath off? You hit a target tidal volume. You set 200 mLs, 400 mLs, 600 mLs, whatever. That's what turns the breath off. And that's usually linked to the flow, to a set flow mechanism. Another common way to turn off a breath is a timer. deliver the breath for 0.6 seconds, 0.8 seconds, 1.0 seconds. And that's usually linked to the pressure flow algorithm, or the pressure breath delivery algorithm. And finally, with the pressure support breath, it's a flow cycling mechanism. In other words, you set a pressure, and then as the lung fills, the driving pressure falls because the lung is being stretched. The flow tails off, and when it reaches a certain minimum, it cycles off. So again, triggers, controlled or assisted. And we talk about pressure triggers. The patient makes an effort, the pressure drops, the ventilator fires. Another common assist trigger is the patient makes an effort. It changes a continuous flow. Ventilator senses an effort and says, let's deliver a breath. And some ventilators, a lot of them actually, have both. Again, the two common ways to deliver gas on the left are the set flow. In this example, we have airway pressure, flow, and volume over time. And as you can see, you can set a flow. In this case, it's a square wave of flow. And under these circumstances, the pressure will rise or fall. It's the dependent variable. And this is often linked to a volume cycling mechanism. So flow and volume are set by you, the clinician. On the other hand is the pressure breath on the right, where you set the pressure. And now the flow will adjust to whatever is necessary to get to that pressure. And under these conditions, flow and volume are the dependent variables. They will rise or fall with whatever the patient effort or lung mechanics are. So which one do you use? The one on the left is used by many centers. It guarantees a flow, it guarantees a volume, but pressure doesn't change. If you really, really, really want to make sure you're getting a very precise tidal volume, this is the breath for you. Why use a pressure breath? Because the pressure breath guarantees only the pressure. The flow and the volume will vary. Well, so what? That's what makes the pressure breaths comfortable. Patient effort with a pressure breath is much easier to synchronize with the ventilator if all you're doing is controlling pressure and letting flow and volume fluctuate with patient effort. So the downside of the volume and flow breath is that patients may be uncomfortable. The downside of the pressure breath is that you don't have strict control of the tidal volume. So which one do we like here at Duke? We tend to go for pressure because we like patient comfort. But we will use volume if we're really concerned about stability of the tidal volume. So again, cycling, three common types. You reach a volume, you reach a time, you reach a flow reduction. And airway pressure is always a backup cycling mechanism for safety. So when you think about it, you can then describe what I call the 5 basic breaths. Trigger, target, cycle. And the volume control breath is a machine breath. It triggers it. You set the flow. You set the volume. Volume assist breath. Patient triggers the breath. You set the flow. You set the volume. Pressure control breath. Machine turns it on. You set the pressure. You set a time. Pressure assist breath. Patient turns it on. You set the pressure. You set the time. And the pressure support breath. Patient turns it on. You set a pressure, and then this flow during inspiration, when it reaches a certain minimum, turns it off. And these are shown graphically on this slide here. The solid lines are what you have set. The dotted lines are what will vary with patient effort or lung mechanics. This leads us to the 3 Duke modes. And these are the 3 modes you'll see most commonly used in this hospital. Volume assist control, pressure assist control, and standalone pressure support. Volume assist control simply has volume assist breaths and volume control breaths. That's easy. You turn the breath rate way up on the vent, they're all volume control breaths. You turn the breath rate way down, they're all volume assist breaths. Pressure assist control, same idea. You turn the breath rate all the way up, they're all pressure control breaths. You turn the breath rate way down, they're pressure assist breaths. And just like volume assist control, you set the breath rate somewhere in between, the patient will trigger some, the ventilator will trigger some. Again, our default setting, our default mode in many ICUs here in Duke Hospital is the pressure assist control mode because patients tend to be more comfortable. But volume assist control is a perfectly reasonable alternative if you're really concerned about tidal volume. Pressure support as a standalone mode is just that. It's just pressure support breath. And this is a breath that we tend to use in patients who are recovering, who can trigger every breath, and who will take advantage of the variable flow of the pressure breath to be more comfortable. So those are design principles and the nomenclature we use here. Pressure assist control, volume assist control, pressure support, and again, you can figure out how these modes work if you, again, just think of trigger, what you target, and what turns the breath off. So let's get clinical. And I want to focus on 3 challenges we have in 2016. Lung protection, keeping patients comfortable, and getting them off the machine as quickly as we can. Those are the challenges we face in every ICU in Duke Hospital. Before I go further, I want to re-emphasize a key concept. Mechanical ventilation is not a therapeutic tool. Not a therapeutic tool. It's a support strategy that keeps the patient alive and hopefully avoids complications while other therapies, including the patient's own defense systems, have time to work. So we never cure anybody with positive pressure ventilation. We buy time, and hopefully we don't make things worse. So lung protection, and this has been a paradigm shift over the last 2 decades. And we at Duke have been privileged to be part of this paradigm shift in describing the evidence base, producing the evidence base. So what I've got here is a volume pressure curve. Pressure on the horizontal axis, volume on the vertical axis. And the acutely injured lung has a sigmoid relationship. It's flat down here at the bottom. This is because the lung is collapsed at low pressures, and it takes pressure to finally open these lung units up. And then in the middle, right here, it becomes more steep as we recruit and ventilate alveoli. And then out here, it starts to flatten out again. And the reason it starts to flatten out again is because we start to overdistend. We start to overdistend the lung. So it's a sigmoid shape. And if you think about this sigmoid shape and my little cartoon here, you realize there are at least 3 areas where you can hurt the lung. The most obvious, of course, is over here on the upper right, overdistension. Overdistension occurs when the lung is stretched beyond its normal maximum. Now, you and I, if we take a deep breath, go all the way to total lung capacity, and I measure the pressure across your lungs at total lung capacity, it's about 30 centimeters of water. And numerous animal studies and more recently human studies have clearly shown that once your maximal pressure in the lung is exceeding 30 centimeters of water across the lung, you are going to hurt the lung. Guaranteed. Guaranteed. So how do you know whether you're at 30 or not? We tend to use the airway pressure at end inspiration with no flow. Sometimes it's called a plateau pressure, as an index of that stretch in the lung. So our rule around here is to always make sure your end inspiratory plateau pressure, pressure under no flow, is less than 30 centimeters of water. Now a caveat. This assumes that your chest wall is relatively compliant. And in you and I, and people with normal builds, it is compliant. And that will not affect your plateau pressure very much. But you run into situations like surgical bandages, ascites, abdominal compartment syndrome, and most commonly obesity, that can put a lot of pressure on the chest wall. And so this limit of 30 has to be pushed up a little higher in patients who have abnormal chest walls. But the rule of thumb, again, assuming a normal chest wall, is that we need to keep the plateau end inspiratory pressure at less than 30. On volume assist control, you actually put a pause at the end of inspiration and measure it. With pressure assist control, it's actually a little easier because you can measure the set inspiratory pressure that you're applying, add it to the PEEP, and that's a pretty good approximation of the end inspiratory pressure inside the alveolus. So that's injury number 1. Injury number 2 is down here on the bottom left. Down here on the bottom left. And it's a collapse and a reopening, and a collapse and a reopening injury. This is an injury that occurs because we have sick atelectatic lung units. It's not the fact that they're atelectatic that causes the harm, it's the popping open and slamming shut with every breath that causes the harm. And how do we manage that? We use positive end expiratory pressure to prevent lung collapse. And I'll show you some guides as to how to do that in just a minute. The third injury is right here in the middle. And this is probably the least appreciated, but maybe one of the most important. And that is the tidal volume. The tidal volume. You and I are breathing right now at somewhere between about 5 to 7, maybe 4 to 8 milliliters per kilogram of ideal body weight. And the lung is designed to stay at that tidal volume. Yes, you can have periods of hyperventilation when you exercise, but those are relatively brief in terms of a 24-hour day. And it turns out that this applies to patients on ventilators as well. They need to have their tidal volume in the 4 to 8 milliliter per kilogram range all day long. Even if their plateau pressure is less than 30, and even if you have good lung recruitment, so it's not collapsing and opening, it's not over-distending, but tidal volumes above 4 to 8 milliliters per kilogram have their own mechanism of injury in the lung. So, the big three, when you go in and take care of somebody on a ventilator, is to make sure you have what I call safe settings. You're not over-distending, your tidal volumes are in reasonable range, and you have a PEEP setting, expiratory pressure setting, that is preventing at least a lot of de-recruitment. So let's explore this. It's easy to set the right tidal volume and the right end inspiratory pressure. But how about PEEP? PEEP is a little trickier to set. We don't have I don't have real hard and fast numbers for you here. I want to remind you that PEEP is a two-edged sword. This is transalveolar pressure, positive inflations. And as you can see in this little cartoon, we have collapsed alveolus here. It opens, it collapses, and then it opens again. And what you want your PEEP to do is this. You want to prevent from collapsing. So you put this expiratory pressure right there. But of course, if you put extra pressure at end expiration, guess what? Your end inspiratory pressures are also going to go up. So adding PEEP is always a balancing act. You want to give enough PEEP to prevent de-recruitment, but you don't want to send that end inspiratory pressure, certainly don't want to go above that 30 centimeter of water threshold I described a moment ago. So we use here at Duke what we call PEEP FiO2 tables. And these are simply tables that have been drawn up empirically and used in a number of clinical trials and have been shown to be easy to use and associated with reasonable recruitment and not unnecessary over-distension. So how do they work? You have a target. You have two targets, actually. You have a PO2 target. A PO2 target is somewhere between 55 and 80 millimeters of mercury. And you have a plateau pressure target. Again, less than 30. Those are your two targets. And then you manage oxygenation by adding PEEP and FiO2. So which do you add first? PEEP or FiO2? You add PEEP, you run the risk of overdistension. You add FiO2, you run the risk of oxygen toxicity. So these tables have been drawn up over the years and have been found to be relatively easy to use. And as you can see, I got two of them here. Let's look at the blue one first. This is a more conservative strategy. It adds PEEP in lower levels. And as you can see, if your PO2 is low, you go up a step. And if your PO2 is high, or your plateau pressure is high, you go down a step. And it adds PEEP and adds FiO2. The red bar is another PEEP FiO2 table with more aggressive PEEP in it. And the reason I'm showing you these two is because, in fact, in several meta-analyses, the blue table seems to work best in less injured lungs. What's a less injured lung? A P to F ratio less than 200. A red table works best in more sick lungs, P to F ratios less than 200. And on every ventilator in Duke Hospital is a little table, or is a simple little chart that consolidates these two tables, and it guides you and the respiratory therapist to what the appropriate PEEP FiO2 combination should be, again, with these PO2 and plateau pressure targets. If somehow the table is missing, it's not on the ventilator, if you go on Google and you type in PEEP-FiO2 table, what you see here on this slide is what will pop up. So those guides are readily available. This is just showing you the biggest meta-analysis that's showing you that people with a P-to-F ratio of less than 200 over here on the left, the high PEEP, the red bars I showed you before, actually have a mortality benefit over the low PEEP table. But in patients with less severe lung injury over here, P-to-F ratio is above 200, the low PEEP table, the blue table I just showed you, actually has a better outcome. So again, depending upon how severe the lung injury is in your patient, you can pick which side of the PEEP FiO2 table you want to use. And your respiratory therapists are attuned to these tables and will show you easy ways to apply them. So again, lung protective strategies, plateau pressure is always below 30, tidal volume is always 4 to 8 mLs per kilo, and PEEP and FiO2 balanced against PO2 targets and plateau pressure targets. So that's what guides most of the ventilator discussions on the ICUs in Duke Hospital. A second challenge, keeping patients comfortable. Keeping patients comfortable. Sedation is one of the biggest challenges on the ICU, and one of the biggest drivers of sedation is the uncomfortable patient on a ventilator. And so we need to try to set our ventilator as best we can to synchronize with effort, and numerous studies have shown that the comfortable patient on a ventilator requires less sedation. Less sedation means shorter time on the ventilator and better outcomes. So this is a little schematic illustrating the challenge. So the top graphic here is flow. The middle graphic here is airway pressure. These are two things that can be monitored on the ventilator. And down here are electromyograms. This is a diaphragm EMG, and this is the transverse abdominis EMG. Diaphragm is the major muscle of inspiration. This is one of the muscles of expiration. And as you can see, this patient is making an effort here, and it crescendos here right in the middle and then tails off. And then the patient's brain wants to exhale. And what you want your ventilator to do is follow this little dotted blue line right there. So you want the pressure to rise as the patient effort begins. You want the pressure to peak when the effort is at its greatest. And you want the pressure to fall when the patient effort ceases, right? Right. This is not always easy to do. And oftentimes on ventilators, if you look carefully, you can see these big negative swings in the airway pressure, indicating the patient is flow starved. The pressure and the flow are not keeping up with the patient's effort. Sometimes you can also see that the patient may exert pressure at the end of the breath. Why? They want to turn the breath off. They want to turn the breath off. And that's the expiratory muscles coming in. So looking at the graphics and seeing the airway pressure being sucked downward or the airway pressure being pushed upward at the end of the breath tells you that the patient is out of sync. The patient is out of sync. And these very vigorous efforts you see here may actually trigger second breaths, double breaths. So it becomes a real art form to keep patients comfortable. And again, this is why we at Duke like to use the pressure modes. Again, the pressure modes will tend to adjust flow to patient effort. And in the pressure support mode, because as flow tails off, that reflects patient effort is tailing off and the lung is filling, allows a little easier synchrony to the end of the breath. So again, at Duke, we tend to default to the pressure settings. Pressure assist control for the sick patient, pressure support for the recovering patient. But again, you don't have control over the tidal volume with pressure breaths. So if you really are concerned about tidal breath tight control, then volume assist control is going to be your choice. But again, the downside of volume assist control, you've set a fixed flow. It will not adjust to the patient, and comfort can become a real issue here. So common dyssynchronies, the trigger is insensitive. The trigger is insensitive. It's not picking up the patient effort. Now that's usually not too much of a problem today. The ventilators of today are quite sensitive, and they are very good at detecting patient effort. But it's something to think about. Intrinsic PEEP. Intrinsic PEEP. What's intrinsic PEEP? Intrinsic PEEP is PEEP that develops inside of an obstructed disease patient. The lung hasn't emptied. And as a consequence, there's a pressure remaining inside the alveolus. Why does that cause a triggering problem? Well, think about it. Here's alveolar pressure and here's circuit pressure in you and I. Our alveolar pressure at end expiration is exactly the same as circuit pressure. So for us to trigger a breath, what do? We drop our alveolar pressure, instantaneously circuit pressure drops. Ventilator senses the pressure drop, fires the breath. In these patients with intrinsic PEEP, it's way up here. What does that mean? That means the patient has to overcome all of that pressure before the circuit pressure finally changes. So, alveolar pressure way high compared to circuit pressure puts a triggering load, and patients may not even be able to generate enough effort to trigger the breath. You get missed breaths. And you can sense this or see this by just looking at your patient. And you'll see a patient who's pulling hard and the ventilator doesn't respond. Or if it does respond, it responds very slowly, a big lag, intrinsic PEEP. And finally, double triggers. And this is caused by a mismatch of the patient's drive and the ventilator. And this is also a difficult adjustment to make to get your triggering just right and your breath cycling mechanism just right. I've already talked about flow dyssynchrony, where the patient is not getting enough flow and the airway pressure graphic is sucked downward. And finally, cycling, the breath is too long, patient fights to turn it off, the breath is too short, the patient is left wanting more and may actually, as I say, trigger a second breath. Going in and having your respiratory therapist show you the graphics on patients, I think can help understand some of these dyssynchronies. Our therapists, especially with pressure modes of ventilation, are pretty good at minimizing these dyssynchronies, but they're real and they occur. So this is just an example of that intrinsic PEEP phenomena I showed you a moment ago. We've got on the top graphic here pressure, and then here's flow, and here's volume, and down here is the diaphragm EMG again. And look right here, this patient's making a big effort. Look at that, huge effort, and nothing's happening. And why is nothing happening? Because this effort is not enough to overcome the intrinsic PEEP and affect the circuit PEEP. One of the tricks we'll use sometimes when there is intrinsic PEEP and a triggering problem is we'll add PEEP. Well, why would that help? Remember, what's happening here? Our patient's pressure is way up here, our circuit pressure is way down here, the patient has to pull all the way down before the breath triggers. Well, here's what happens if you add a little intrinsic, or if you add some circuit PEEP. It gets closer and makes it easier to trigger. Now, you don't want to give more PEEP than's inside the circuit or inside the lungs, but you just titrate it up. Add 4 or 5 centimeters of water. And if you're doing the right thing, the patient should feel more comfortable. And this is just a graphical display of how adding a little bit of PEEP, a little bit, to somebody with bad intrinsic PEEP can actually help the triggering process. So focus on comfort. Look at the trigger, look at the flow delivery, look at the cycling, and make sure your vent is set as close as possible to patient effort. Again, pressure breaths tend to make this a little bit easier, and don't forget the role of perhaps in intrinsic PEEP, COPD, asthmatic patients, maybe a little extra PEEP to help with the triggering process. And the final big challenge is getting patients off as quickly as we can. So there are various approaches to what we call ventilator liberation. And for many years, we used to have a gradual support reduction strategy, what we called weaning. Increase the number of mandatory breaths. Decrease the number of mandatory breaths and increase the number of patient breaths. Reducing the inspiratory pressure on pressure assist control or pressure support. And there's some systems that will automatically reduce the pressure for you. But at the heart and soul of ventilator liberation really is the daily spontaneous breathing trial. The daily spontaneous breathing trial. And this needs to be tied to a sedation protocol. sedation protocol and weaning protocols are intimately related. Some people even advocate doing spontaneous awakening trials where you actually cold turkey the patient. I'm not sure I believe that's necessary, but I do believe very strongly that getting patients off the ventilator must include a protocol that minimizes your sedation to RASs of 0, -1 to make this all work. This is a summary of a number of studies done a number of years ago looking at probability of remaining on the ventilator on the vertical axis and days of mechanical ventilation on the horizontal axis. And what I want you to notice right here, this graph right here, the one on the far left that gets patients off the ventilator quickest, you know what? Doesn't wean the patient at all. There's no adjustments of inspiratory pressure. There are no adjustments in respiratory rate. There are no technically weaning going on here. The only thing that's happening here is a daily spontaneous breathing trial. Daily spontaneous breathing trial. So our rule around here is if the FiO2 and the PEEP are in a safe range, less than 40%, PEEP of less than 5 to 8, and the patient can trigger the ventilator, it's time to do a spontaneous breathing trial. And it has to last at least 30 minutes, no more than 120 minutes. And you follow the patient's comfort and breathing pattern, kind of an integrated assessment for tolerability of being able to breathe with just a little bit of inspiratory pressure to overcome the endotracheal tube. Either a straight CPAP trial, sometimes people just take them off and put them on a trach collar or a T-piece. Sometimes you just dial the pressure support down to about 5 centimeters of water. Why 5? That's the pressure required to overcome the resistance of the endotracheal tube. So that's how you do a spontaneous breathing trial. It ought to be done every day in people with PEEP and FiO2 in the manageable range and who can trigger the mechanical ventilator. And it is the way to most rapidly get patients off the ventilator. This is an old study. It was the first of its kind. Many studies just like it since then, where daily spontaneous breathing trials were put into practice. This was done at Vanderbilt, and as you can see, a very impressive reduction in ventilator days, in weaning days, ICU costs, and everything. So this is a standard of care in our institution. So I've tried to again focus on the big three: lung protection, plateaus less than 30, tidal volumes 4 to 8, appropriate levels of PEEP. I've tried to focus on patient comfort, using pressure-targeted modes, and looking very carefully at your graphics to make sure you've set the ventilator up to match patient effort as best as you possibly can. And finally, minimizing duration of support. The important role of the spontaneous breathing trial. Weaning inspiratory pressure and weaning mandatory breath rates probably are not necessary as long as you get to the spontaneous breathing trials on a regular basis, daily basis, when your PEEP and FiO2 are in a reasonable range. Again, we use PEEPs of around 5 to 8, FiO2s down in the 40% range. So my last segment is to talk a little bit about non-invasive ventilation. So non-invasive ventilation is actually, non-invasive ventilation uses the same principles I just described before. The same basic modes are available. The most common devices usually are just pressure devices. That is, they provide either pressure assist control or they provide pressure support. Some of the fancier non-invasive systems do have volume assist control, but that's not available in all of them. If you're using a conventional ventilator to drive a non-invasive system, a mask system, you got to be really careful because a mask inherently has leaks. And a conventional ventilator that we use in the ICU does not compensate for leaks very well. Now, the newer ventilators we have in the ICU actually have what they call non-invasive modes. They're not really non-invasive modes. They're the same basic modes they have. It's just that they have put an extra level of software control in there that adapts to the leaks that are inherent with mask systems. Dedicated non-invasive systems already have these leak compensation mechanisms in them. We use the term BiPAP to describe these dedicated non-invasive systems. It's unfortunate we've adopted that name because it's actually a trade name, but it is what it is. And BiPAP is at least in Duke Hospital, is used to represent a dedicated non-invasive ventilator. That is to say, it's got pressure assist control, pressure support, possibly volume assist control, but it's got the inherent leak compensation mechanisms built in, and it can be used with a mask. The mask interface is absolutely crucial, and they range all the way from nasal masks that just cover the nose to oronasal masks, all the way up to full face masks. And in general, the smaller the mask, the more comfortable it is. But again, the smaller the mask, you may get more intolerable leaks. It may be more difficult to provide the ideal amount of pressure you want to give. So it's a balancing act. And the therapist will go in, and it's really important when you put somebody on non-invasive ventilation. You can't just go in and slap the mask on. I heard somebody refer to, let's go in and slap the PAP. You don't slap the PAP. You go in, it may take 10 or 15 minutes of getting the right mask, adapted to the patient, getting them comfortable. You don't attach it immediately. You kind of put it on them in front of them, and then slowly get it closer and closer to them until they are comfortable and in sync with your machine. It's a real skill set, and it can't be done in a hurry. The strongest evidence for non-invasive ventilation in terms of outcomes is in the obstructive airway disease patients, especially COPD. This is an older meta-analysis. There are more studies in this now, but the trend is exactly the same. The trend is exactly the same. The need, they're calling it non-invasive positive pressure ventilation here, NPPV, but you get the idea. And as you can see, it's really an impressive risk reduction for intubation when you use non-invasive ventilation in COPD. The evidence in hypoxemic respiratory failure is less clear. It may help, but as I showed you earlier, we talked about high flow, high humidity systems. For those patients with hypoxemic respiratory failure, it's probably better to go to those high flow, high humidity systems at 40, 50 liters a minute than to try to put a BiPAP device on hypoxemic respiratory failure. Not true in obstructive airway disease. CPAP, just straight CPAP, it's not BiPAP. BiPAP means inspiratory pressure is higher than expiratory pressure. CPAP can also be applied through a mask, and its most effective therapy is either in the sleep apnea population or in acute care, like you and I deal with, in the patient with acute cardiogenic pulmonary edema. So these mask systems are helpful. They do reduce intubations. Certainly non-invasive ventilation in COPD, obstructive airway disease, maybe in asthma. Certainly CPAP in cardiogenic pulmonary edema. And as I say, for the hypoxemic respiratory failure, this high flow system may be the better way to go. So non-invasive ventilation in obstructive airway disease, especially COPD, the front end and the back end. I've been talking about trying to keep people from getting intubated. As I showed you, the data is pretty strong there. But there's also a growing evidence base that says maybe it can be used on the back end as well. So you got a COPD patient, they can protect their airway, but they fail your spontaneous breathing trial. Maybe, if they've gotten a little better, you could take them, extubate them, and put them right to a mask system. And there's some evidence that says in the COPD population that is recovering and can protect their airways, extubating even a failed spontaneous breathing trial right to a mask system may allow the patient to remain extubated. Failed extubations, again, for the COPD patient, you thought they were going to fly, they didn't. The mask may rescue you, again, if it's not an airway protection issue. But in hypoxemic respiratory failure, not so. Not so. They need to be re-intubated. All right, let me summarize now and conclude. Respiratory failure is a challenge for all of us in acute care medicine. And I've tried to cover, briefly anyway, two of our therapies for management: delivering oxygen and delivering positive pressure ventilation. In the oxygen world, we have simple systems like nasal cannulas, all the way up to non-rebreathing systems in the conventional world. They can get pretty close to 100%. And then the next step up is the high flow, high humidity systems that not only can supply you with 100% oxygen, but can also supply you with a little bit of CPAP and can wash out dead space to make ventilation more efficient. In the world of positive pressure ventilation, we got the 3 Duke modes: volume assist control, pressure support, and they can be understood if you understand pressure triggers, targets, and cycling mechanisms that you set on your ventilator. The challenges: lung protection. One more time. Plateaus less than 30, tidal volumes 4 to 8, PEEP adequate to recruit the lung or prevent de-recruitment but not over-distend. Synchrony, know how to look at ventilator graphics and recognize dysynchrony. The use of the pressure-targeted modes to help with synchrony, and understanding how important this is in reducing sedation. Finally, getting patients off quickly, tying spontaneous breathing trial protocols to sedation reduction protocols. This is the name of the game. And all 3 of these aspects of managing ventilators can have profound effects, not only on the length of stay on the ventilator, but also on long-term outcomes, including mortality. So, that concludes my comments with you today. I hope this was of some help to you. I'm around. My email at Duke is neil.mcintyre@duke.edu. If you have questions or comments, why don't you just come by and chit-chat about ventilators. Always glad to do it. Thank you all very much for your attention.